first Global Health Lunch and Learn that's a hybrid event. We have quite a few people online and a number of people in the room. So I wanted to thank everyone for coming, and I'm just delighted to have Dr. Carmen Logie, Logie, I'm sorry, join us today. It is a real privilege, and what a great opportunity. So she's currently, Dr. Logie is the Canadian Research Chair in Global Health Equity and Social Justice with Marginalized Populations, and she works at the Faculty of Social Work at the University of Toronto. She's visiting UBC, I think it's for the month of October, is that correct? She is working with the Center for Gender and Sexual Equity and the UBC as a Peter Wall visiting scholar, which is a really big honor. I think an honor for us to have her here at UBC. She is a leads global research focused on sexual health and rights, aimed at understanding and addressing intersectional stigma and its sexual and reproductive health impacts with a focus on HIV. So I'm really delighted to have her here today. We'll get started. We have a moderator, Marianne Bidler, who is an assistant professor of obstetrics and gynecology, and she's on the Zoom chat. Dr. Gina Ogilvie will be joining us shortly as well in the room. And we're very delighted to have you. At the end of this session, I will put out a little bit of food for anyone that has to run to class and didn't have anything to eat, so you can grab and go, but we can't eat in here. So I couldn't provide you lunch, but I can provide you a grab and go. With anyone else, are we good to go? Thank you so much. Yes.
Thank you so much for having me here today, and I really want to thank the Peter Wall Fellowship. They have been so flexible. I was originally going to be here in May 2020, but they were flexible enough to delay it a year and a half due to the circumstances. And I just also want to thank Kate Shannon and the Center for Gender and Sexual Health Equity. And I also want to acknowledge that I'm on the unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh. And yeah, I'm grateful to be here. So you can follow me on Twitter, at Carmen Logie, and I'm going to get started. So what I'm going to talk about today, and I'm just timing myself, so if you know what I'm doing, that is. So I'm going to be talking about sexual health and the Sustainable Development Goals, and specifically how we might think differently about the Sustainable Development Goals so we leave no one behind in the global health agenda. So there's three parts to the talk today. First, I want to look at the opportunities and gaps regarding the Sustainable Development Goals. Then I want to discuss sexual rights, sexual pleasure, and sexual health and their interconnectedness. And I'm going to end off by talking about why this matters, why we should be caring about what I'm talking about, why what measured matters. And so first I just want to, briefly go over the Sustainable Development Goals, although I know some people probably know more, some people might know a little less. They have a very ambitious goal by 2030, so that's coming up, agenda about transforming our world. And so this is part of the statement of the Sustainable Development Goals. As we embark on this great collective journey, we pledge that no one will be left behind. Recognizing that the dignity of the human person is fundamental, we wish to see the goals and targets met for all nations and peoples and for all segments of society. And we'll endeavor to reach the furthest behind first. So this is the mission of the Sustainable Development Goals. And you might know that there are 17 Sustainable Development Goals. For the sake of time, I'm focusing on part of one, which number 3, good health and well-being. And why this matters for us sitting here in Canada is we signed on to the global the Sustainable Development Goals. So Canada is supposed to be promoting the Sustainable Development Goals in Canada and across the globe. And so I mentioned that I'm focusing today on 2 elements of Sustainable Development Goal 3, good health and well-being. Ensures healthy lives and promote well-being for all at all ages. And specifically, I'm going to be talking about Target 3.3, which is around by 2030, end the epidemic of AIDS. Quite ambitious, and some other epidemics, but I'm focusing on the HIV epidemic. and target 3.7 by 2030 ensure universal access to sexual and reproductive health care services, including for family planning, information and education, which is what I'm going to be focusing on today, and integrating reproductive health. So the Sustainable Development Goals were really developed to be more transformational, more ambitious, and more framed within human rights than the Millennium Development Goals.
So we're gonna just stop for one second. We just have to move you because they're having a hard time seeing you, which I didn't realize. Is that okay?
That's
I
fine.
see you. Where can she go?
Yeah, so right now the camera's like focusing in that corner because the microphone is there. So so right where those two ladies are sitting.
Yeah, I think I have enough juice.
Yeah.
I apologize.
There's an outlet over there as well if you need one.
The pilot hybrid meeting. Is here good?
Yeah.
Thank you very
perfect.
much.
No problem. Stretch break.
Okay, everybody at home can stand up, move around.
Can you see me here?
Is that better? Zoom folks?
Yes, that's great.
Thank you.
So what I think is really exciting about the Sustainable Development Goals, or the SDG, is it's really about reducing inequalities, building inclusive societies, and protecting human rights. And there's a statement, and there's many statements, that all of these goals should be met among all persons. And specifically what's mentioned is age, disability, race, religion, and quote, other statuses. But there are some noticeable gaps, and that's what I'll be focusing on today. So there's not a focus on advancing sexual rights. So there's a focus on advancing sexual health, reproductive health, and reproductive rights, but not sexual rights. So it's only mentioned once in the SDGs with regards to knowledge of sexual rights, so not actually realizing sexual rights. And so you might ask, what are sexual rights? So sexual rights, as defined by the WHO, is when we apply existing human rights to sexuality and sexual health. Sexual rights protect all people's rights to fulfill and express their sexuality and enjoy sexual health, with regard for rights of the others, and within a framework of protection against discrimination. So now I'm going to go to the second part of the talk today, which is really, why do sexual rights matter when we think about sexual health? What about the role of sexual pleasure and sexual health? So there's a long history, how we even became to be thinking about the importance of sexual rights, lying in grassroots activism, advocacy, and social movements, including movements among people with HIV, sex worker movements, and lesbian, gay, bisexual, trans, queer, and other sexually and gender diverse or LGBTQ movements around sexual rights. And they are fundamental. We cannot realize sexual health without realizing sexual rights. As Richard Parker, who's I'm lucky enough to work with Richard Parker, and he's one of the people who started writing about sexual rights decades ago. The road to sexual health is underpinned by the struggle for sexual rights. Without being firmly rooted in a conception of and commitment to sexual rights, sexual health promotion can never be effective. So in essence, if we don't have access to sexual rights, we will never realize optimal sexual health. And I just want to give a shout out to my colleagues at the Center for Gender and Sexual Health Equity. I took this photo in their office because I know that they are always engaging in activism around sexual rights. So this was Andrea Crusi's poster around decriminalizing sex worker and sex worker rights. And so what is really interesting when we think about sexual health is it's actually beyond physical health, and it's a multidimensional construct. So the WHO in their 2017 document describes sexual health as requiring a positive and respectful approach to sexuality, sexual relationships, having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. They actually break sexual health into 4 components. One of them is comprehensive sexuality education information. The second is sexual and gender-based violence prevention, support, and care. third is preventing and controlling HIV and other sexually transmitted infections. And then the fourth is addressing sexual function and psychosexual counseling. So a lot of times when people think about sexual health, they don't think about this multidimensional nature of sexual health. And this is a framework that was presented alongside this conceptualization of sexual health to operationalize sexual health and its linkages to reproductive health. I know this is small and you won't be able to read it, but what is in blue are the 4 components of sexual health that I just described: the preventing and controlling HIV and STIs, sexual and gender-based violence, comprehensive education and information, and sexual function and counseling. But what's interesting here is that, and I know you can't see this, I'm describing it though, the circle around it is the climate. And that climate is gender and sexual norms, cultural and social norms around sexuality, laws, policies, and strategies. And what I want to talk about next is what's on the bottom. And I've printed it off on the next slide because it's hard to read. This is what's considered the foundation of realizing the interconnectedness of sexual health and reproductive health are respect, protection, and fulfillment of human rights, are looking at the multi-level influences of sexual health, looking at diverse needs across life courses and populations, and evidence-based, respectful, and positive approaches to sexual and reproductive health. So I've written these out. So this is what is on the foundation of that. And I want to just spend a few minutes today talking about how we are in trouble because we have not realized any of these foundations that are required to realize optimal sexual health. And I'm going to just give some very brief examples and then go into some more in-depth examples. So these 4 components that are at the foundation, including cultural and social norms around sexuality, gender and socioeconomic inequalities, human rights and laws, policies, regulations, and strategies. So just one example, cultural and social norms around sexuality. There are thousands and thousands and thousands of articles written around how stigmatizing cultural and social norms around sexuality are linked with reduced uptake and access to comprehensive sexuality education, HIV testing, HIV care engagement. Our teams have documented this all around the world with regards to HIV stigma, lesbian, gay, bisexual, and transgender stigma, there's sex work stigma, and really the intersectional forms of stigma discrimination based on race, on gender, on sex work, on drug use, all converge in ways that create stigma and discrimination regarding people really being able to realize their full potential of sexual health and sexual well-being. And second of that foundation is gender and socioeconomic inequalities. I probably don't need to talk to you today, and it could be a talk in and of itself about gender and equitable norms all across the world. In North America, every country in the world, inequitable gender norms are linked with reduced power to negotiate safer sex, to negotiate condom use, are linked with increased exposure to sexual and gender-based violence. We've noted this working with refugee youth in Kampala, working with women living with HIV in Canada. There's increased experiences of sexual and gender-based violence among, I'm just going to give an example, in Canada, women living with HIV, and there's also increased poverty, including food and housing insecurity among people living with HIV across the globe. And human rights, it's been well documented, including by Kate Shannon and the team at Center for Gender and Sexual Health Equity, among many other people around the world, that when you limit access to human rights for lesbian, gay, bisexual, and trans people, it's increased with, it's associated with increased violence, police violence, reduced access to HIV testing, HIV care. We've documented this, police harassment and HIV vulnerabilities, for example, in our work in Jamaica, in our work in Eswatini, formerly Swaziland, and Lesotho. There's systematic reviews that human rights violations are linked with reduced access to HIV testing, reduced engagement in HIV care, and increased exposure to sexual and gender-based violence. And fourth, there's a lot of research that has been documenting when laws change, people's access to healthcare changes, especially when it comes to sexual health. So, there's been work done by Shira Goldberg and Kay Chen's team around looking at sex workers in Vancouver and these laws that are, around sex work that actually increase risks of police violence, client violence. We've seen the immediate effects of laws such as the Same-Sex Marriage Prohibition Act in Nigeria. In Jamaica, there's direct relationships between a lack of rights protection in the law and the way that people are treated by police. So there's an abundance of evidence. So I'm just showing that the foundation here has problems. So I was Googling images for this presentation, and I was like, I want an image that the foundation is cracked. And one of the common Google searches is, our house has foundation problems. I'm like, this is true. So those examples were just to say, we have a problem here already when we look at these necessary foundations for realizing sexual health. And we see all across the globe that there is limited protection for sexual rights, especially when it comes to sex workers and LGBTQ people. So for the two examples I'm going to give for the SDG target 3.3 and 3.7, I'm just going to give examples of the relevance of thinking about naming sexual rights and thinking of specifically naming LGBTQ people and sex workers. Both of those populations are not mentioned anywhere in the SDGs, and sexual rights, as I mentioned, are not a focus. I also want to say that these are not discrete populations and that intersectionality matters. So there are LGBTQ people who are sex workers, there are sex workers who are LGBTQ people, and not everybody's experience is the same. Everybody has different experiences based on intersectionalities of race, ability, immigration, gender, poverty, substance use, among other identities. And so sexual rights are the missing piece of advancing HIV prevention and care. We know that violence, stigma, discrimination, we have documented this extensively, reduce access to and engagement in HIV healthcare, they compromise quality of life among LGBTQ people and among sex workers, including sexually and gender diverse sex workers. So the evidence is extremely clear that without sexual rights, LGBTQ people and sex workers are not realizing optimal HIV prevention and care outcomes. And as I mentioned, naming people matters. LGBTQ folks, sex workers are not named, yet 40 years into this pandemic, these are two of the groups most impacted. In the UNAIDS latest statistics, key populations, which include sex workers, gay men and other men who have sex with men, people who inject drugs, trans people, account for 65% of HIV infections globally. That's most infections, it's almost 2/3. And HIV acquisition likelihood in the latest UNAIDS stats is 26-fold higher for sex workers, 34-fold higher for trans women, and 25-fold higher for gay men and MSM. So if you have an SDG focused on naming the AIDS epidemic and you're not naming groups that are this much higher at risk, I'm not really sure how we're going to reach this goal by 2030. And as I mentioned, the lack of human rights protection. So there's a lack of human rights protections. The ILGA has a really great report looking at the landscape of rights for LGBTQ people globally, and they differentiate between laws that actually criminalize same-sex practices, which exist, the last time I looked was in 69 countries, and then other places that have a lack of human rights protection. So there's two different ways that people can have human rights protected or not protected. So if people are criminalized, and then if there's not criminalization, but still a lack of human rights protection. And this is, as I mentioned, impacts gay men and other men who have sex with men, but it also impacts lesbian, bisexual, and queer women. We see data out of South Africa, out of Lesotho, and in our own team's work in Jamaica, where there are sexual health disparities, including exposure to sexual violence, reduced access to sexual health care because of stigma and discrimination. And we also know that a lack of recognition of gender identity is related to lower service engagement and increased HIV risks. And our work looking at these issues actually can matter. I've been, our work in Jamaica with LGBTQ folks, I've been asked to be an expert witness on 5 asylum cases for LGBTQ folks from Jamaica seeking asylum in the United States. And when you document human rights violations and you document these things, it actually matters for people's lives, and people realizing or coming on the path to realizing human rights. And so, this is a recent article in Nature Communications that show how punitive laws and a lack of rights protections for sex workers is actually linked with higher HIV prevalence across 10 sub-Saharan African countries. So I was just talking about the lack of human rights mattering for LGBTQ folks. They also matter in sex workers, HIV risk environments. And so we know, as I've mentioned, that sex workers have increased HIV prevalence compared to non-sex workers, and this is largely shaped by stigma and criminalization. And I'm giving 3 examples. One is in Canada, and the other 2 are global examples. This is some recent analyses. It's in revision right now, where we looked at what about women living with HIV who are engaged in sex work? What are their health outcomes like? And we found that it's quite common, and this is from the CHIWOS, the Canadian HIV Women Sexual and Reproductive Health Cohort study, with 1,422 women. We found that almost 9% reported sex work over the course of these 5 years. The study was going between 2013 and 2018, and it varied over time. And that recent sex work, so in the past 6 months, was linked with depression, hazardous alcohol use, recent injection drug use, and nearly 2.5-fold higher risk of past 3-month violence. And this, I'm not presenting all the findings here, I'm happy to share those with you, but we adjusted for 15 different sociodemographic variables. So you can see that just thinking about, even in Canada, women living with HIV, there's dynamic sex work trajectories, and that we need to think about violence prevention and harm reduction in order for people to realize sexual health, which, remember what I said earlier, includes freedom from sexual and gender-based violence. And intersectional considerations in this analysis were that women reporting sex work were more likely to be lesbian, gay, bisexual, or queer, identify as indigenous, identify as transgender, report a lower income and lower education, and be housing insecure. Also more likely to be lost to follow up. And what gets me is that we've been talking about syndemics lens for more than 20 years. So Meryl Singer conceptualized syndemics as including intersecting social and health disparities. This is more than 20 years ago, looking at violence, substance use, and HIV. And more than 20 years later, this is what we're still reporting. So this is a persistent problem, and the fact that I'm still reporting a framework from 20 years ago shows that we haven't gotten to the root of it. We haven't been getting to what is the root cause of violence targeting sex workers, for instance. What's the root cause of that? And I think it is in that foundation, a lack of gender equity, a lack of sexual rights for sex workers. So the second example, I've been working in Jamaica since 2013. We had a study for several years where we were looking at HIV vulnerabilities among LGBTQ folks. And we found that those who were sex work involved were so much higher at risk for violence and HIV that we did a second study focusing just on sex workers. And every single qualitative, quantitative analyses, we documented how stigma towards LGBTQ people and stigma towards HIV were linked with lower HIV and STI testing, increased exposure to sexual violence. And more recently, with the community-based partners at Jamaica AIDS Support for Life, what are the goals now? because that project ended, and they were like, well, let's think about care. How do we engage people living with HIV in care? I don't know who's aware of the 95 goals of UNAIDS, but the goal is that 95% of people know their status, 95% of those people will be on treatment, and then 95% of those people will be virally suppressed in order to end the AIDS epidemic. But in Jamaica, only 40, and this is UNAIDS 2020 stats, only 44% of people are taking ART who are living with HIV. Only 35% of people living with HIV have an undetectable viral load. HIV prevalence is much higher than the national prevalence, which is less than 2% among sex workers. Gay, bisexual, and other men who have sex with men have a 29.8% HIV prevalence, and trans women have a 50% prevalence in Jamaica. And stigma criminalization really matters. As I mentioned, we've been documenting this, but also just 2020 Jamaica People Living with HIV Stigma Index, and people are delaying HIV testing due to fears of stigma. And that includes delaying accessing treatment. And this is something, I'll briefly talk about our current study. This is and it's also founded in reality, grounded in reality, because most people, like 48% of people, are reporting that they're experiencing stigma and discrimination. And so for the current study we're conducting, and I'm not going to go into depth about these findings for the sake of time, but we conducted 9 focus groups with young people living with HIV aged 16 to 24, including 3 with sex workers, 3 with trans women, and 3 with gay, bisexual, and other men who have sex with men. And we did 3 focus groups per site in Kingston, Montego Bay, and Ocho Rios. I'm actually not going to I'm not going to go into depth about our findings, but just to say that over and over again, people reinforced how much stigma there was around sex work and around people living with HIV and around trans people, MS, and gay, bisexual, and other MSM. And that this was directly related to people's challenges going to access HIV medication and taking it. And also linked, stigmatizing family norms were linked with homelessness, were linked with discrimination in the household. I actually co-facilitated a couple of these focus groups before the pandemic, and was there when the young gay man said that his mom separated the utensils. She found out he was positive, wouldn't let him hug his sibling anymore, and being told that they should probably be better off dead. And so what we did for the second part is we created comic books out of the qualitative findings, and we're now going to be using this in individual interviews with people. We had to sort of pivot because of the pandemic, what our original plan was. And so we created these, and we're going to be giving the blank versions as well. And so this, was an example of various scenarios that people discussed about having challenges taking medication. If families find out, if their workplace finds out, if they don't have enough food to eat, if they don't have money to go to the clinic, if their partner is going to leave them. We also have a comic here about moving positively, and it's done in patois by our partners on the ground. So just something we're trying to go deeper into understanding what can we do, how can we intervene in order to support people into realizing well-being and non-discrimination in their lives to better support them to engage in HIV care. And just the third example I'm going to give around the importance of sexual rights for sex workers is with our work. I've been working for the last almost 4 years in Uganda with urban refugee and displaced youth in Kampala. And so this is just from a recent article we published this year on intersecting forms of stigma and HIV testing among urban refugee adolescents and youth. And so we applied this health stigma discrimination framework. So I've worked with the NIH on some teams on NHIV stigma. So this is one of the stigma frameworks that we recently published in a special issue in BMC Medicine on stigma and global health. And so we actually found that refugees' narratives really mapped onto a lot of these stigma experiences. And I'm just going to focus on the sex work narratives. Also to show that if we ignore sex work, then we're ignoring some of the most marginalized people. You know how I said that the SDGs are aiming to go to who's left behind first, who's left behind the most first. So I'd say refugee sex workers are pretty left behind. They experience, brief context, Uganda has the most refugees in sub-Saharan Africa, 1.4 million. And a lot of refugees that are working at Kampala don't speak English, they speak French, and they speak other languages. So from the DRC, speaking Swahili, from Rwanda, from Burundi. And so they're actually not able to access most services because they don't actually speak the language. And when it comes to sex work, which is not legal, this legal precarity of being a refugee youth and a sex worker really profoundly impacts people's engagement with HIV testing. So it's just a couple of narratives. These are from refugee sex workers. They're not Ugandan. Some of them are not registered. It's not formally, they're asylum seeking. So that limits them from accessing HIV testing because they're feeling like they're maybe illegal, they're not accepted, and they're migrants, and they're a sex worker. And then, as I mentioned earlier, sex workers are also LGBTQ folks. And so both of those things are criminalized. There are sex workers who sell sex to men and women. So they also might be afraid of accessing care because of legal precarity and what's going to happen to them. And another sex worker talked about sex work being illegal in Uganda and not knowing, when is it safe to disclose to a healthcare worker why they're coming in for repeated sexually transmitted infections testing. At some point, people are saying, well, this is why I'm here, because the health worker is like, why is this happening? And so people, they know they'll be asked a lot of questions, and these health workers are biased. So this is just a couple of examples from our work. Obviously, for the sake of time, not that in depth, but happy to share more findings. And just to say that intersectionality matters, we actually found, and this is just published recently in AIDS Care, that there was differences by gender in transactional sex and HIV prevention cascade engagement. In a quantitative study we did, where we found that actually young women who were engaged in transactional sex in this sample were more likely to report condom use and condom efficacy, but not testing. But among young men, when they were selling sex, they were actually reporting lower, like reduced HIV testing. And we also similarly found that adolescent boys and young men in Jamaica who are sex work involved were less likely to engage in HIV care. And that could be that stigma around men selling sex is different. And there's less services tailored for young men selling sex than young women. So they will experience a different kind of stigma, especially if they're selling sex to other men. And so my time is running, but I'm gonna keep going forward. So the second example I wanted to give for the SDGs were around universal access to sexual and reproductive health care services, which is target 3.7. And so it's probably not a surprise to everybody that sexual health education is largely based on the needs and realities of heterosexual and cisgender people. And that this not only harms sexual health among LGBTQ folks, but it's also been linked with poor mental health and social exclusion. And comprehensive sexuality education is quite exciting. It's around gender, power, and rights. So it's sexual agency and empowerment. It focuses on synergies between rights and agency, positive sexualities, SRH, sexual and reproductive health, and power. And it matters. I mean, when we have affirming sexual health education, it's linked with reduced STI acquisition risks, reduced unplanned pregnancy. All of these are part of the SDGs. Safer climate, so less stigma discrimination towards LGBTQ folks. And we also know that's true with sex work affirming services. And this is a recent article I really like in The Lancet, just published this year, on sexual well-being by Mitchell and all. And they look at these 4 interconnected dimensions of realizing sexual health. So how sexual health is connected with sexual pleasure, and it's connected with sexual well-being, and connected with sexual justice. And sexual well-being include sexual safety, sexual respect, sexual self-esteem, comfort with sexuality, self-determination. These are all things that can actually be integrated into comprehensive sexuality education. And sexual pleasure is actually diverse physical and psychological satisfactions of sexual experiences, self-determination, consent, privacy. This is linked with both events. So here, you see this is person-related and event-related. So it's related with events, but also relational dynamics. So it's also what kind of relationships are we in? And obviously, if you're realizing sexual rights, equality, non-discrimination, autonomy, you're more likely to be able to realize this facet of sexual health and sexual pleasure. And I'm not going to go over this for the sake of time, but I was lucky enough to be in Mexico City for the World Congress of the World Association for Sexual Health, and they launched the Declaration on Sexual Pleasure. So I'll download this all online. Then I'll just read the first one. The possibility of having pleasurable and safe sexual experiences free of discrimination, coercion, and violence is a fundamental part of sexual health and well-being for all, which is also linked in the article I just mentioned. There's been a growing body of research on linkages between sexual health, sexual rights, and sexual pleasure in ways that people are creating tools for clinicians to use, how they're informing comprehensive sexuality, for instance. I would really highly recommend checking out the Pleasure Project. If you've not checked it out yet, they have an amazing website. And I was on TV for the first time last night ever live on CP24 talking about Superman's son coming out as bisexual, which is the image on the far right. So, and how representation really matters when we look at even just who kisses, right? Picture of two men kissing is exciting. And if anybody who's following Lil Nas X, like the last video of him pulling out a Durex condom and having sex with another man was revolutionary. And I was, in meetings with a team I'm working with in Jamaica yesterday, and we talked about Superman, we talked about Lil Nas X, because it really matters for people to see themselves reflected as sexual beings in positive, healthy sexual relationships. So I'm just gonna, winding down this talk, but I just want to encourage us to move beyond the risk framing towards pleasure. Sexual pleasure is what motivates most sexual activity, not all, and it can be integrated into our comprehensive sexuality education. There's a lot of evidence out there that it is linked. Improved sexual health and well-being are outcomes of a focus on sexual pleasure, which is about consent. It's about sexual consent. It's about equitable sexual relationships. And we can see where it could fit in the SDGs. It's interconnected with sexual health and sexual justice. It can facilitate enabling environments. It can be part of the conversations in comprehensive sexuality around consent, self-determination, and confidence and negotiation skills for instance, condom use. So the last part, which is pretty brief, is what is measured matters. And I'm sure you've all heard that before. What is named matters. So if the SDG names sexual rights and sexual pleasure, they could name LGBTQ people and sex workers. They are literally only able to be captured in the other category. I'm a stigma researcher. Making somebody belong to an other category, or making a whole group, a whole population of LGBTQ people, which I belong to, and sex workers, just be lumped into an other category. You're literally othering people. That is a fundamental part of stigma, which is creating a distinction between an in-group and an out-group, and a group which is seen as the center and holding the power, and other people who are on the outer margins. And so what is named drives visibility, it drives funding, and it can help us really harness research and funding to address these health disparities that are, I wish I could say they were shocking, but they're so persistent that they're not shocking, even though they're completely unacceptable. I also just want to mention the epistemology of ignorance. The erasure of sex work and LGBTQ people and sexual rights in the SDG is political. There's a lot of evidence that there was people wanting to get sexual rights named in the SDGs, and there was a political pushback about that. And I am sure that's why sex workers and LGBTQ people are not named. The roots are in patriarchy, compulsory heterosexuality. And if anybody has never read Nancy Tuana's Coming to Understand, this is an unbelievable piece. And she talks about ignorance is not innocent. Ignorance is not a simple lack of information. It is constructed, maintained, and disseminated. It's linked with cognitive authority. Practices suppress and erase bodies of knowledge concerning women's sexual pleasure. For instance, what she was talking about in medical histories of how women's bodies have been, body parts are literally erased from certain medical texts around the clitoris, for instance. This is a very unbelievable article, but you can think about if white people don't know about racism, that's not just a lack of knowledge. It's that, I'm a white person. I don't need to experience racism. I don't need to know about it because it doesn't have anything to do with my daily lived experiences. So if a straight person doesn't know about LGBT stigma, similarly, that's not innocent. It's because you hold power and privilege that you don't need to know about that. So this lack of knowledge about people and the lack of naming and the lack of visibility is really rooted in power. And just want us to move beyond vulnerability towards complexity. So vulnerability, and many people in public health have been writing about this, is vague. It doesn't look to the production of power inequities. Who is vulnerable, why not to, and who is not vulnerable? Why are they not vulnerable? No one, including women or sex workers or LGBTQ people, are inherently vulnerable. Vulnerability is shaped and is intersectional. So that could be another consideration for the SDG 5 around gender equity, which is about achieving gender equity and empowering all women and girls. How could we, and I don't have time to go into this, but how could we reimagine this as an intersectional approach to gender that's not binary? And intersectional would also invite us to look at agency, strength, solidarity, and resistance among women and girls, and among all populations that experience social marginalization. So this is my last slide. Call for sexual justice focus that can address violence, stigma, discrimination, trauma-informed, sex-positive public health, sexuality, and sexual expression. And then my latest concept I'm really excited about is the concept of flourishing. In my book, the last sentence of my book was around flourishing, which is about growing luxuriantly in the dictionary. But there's a new body of literature, or at least a new body of literature to me in BMJ Global Health, Social Science and Medicine, talking about flourishing as a way of living in striving to live in keeping with one's values, commitments, and vision for the future in the context of your family and the communities to which one belongs. So instead of a focus on always resilience, which is shaped in your response to adversity, what it would look like to really think about flourishing and how we can realize our own values and our own visions for the future. And I say, if we're going to realize that with sexual health, it needs to be grounded in sexual rights so we can all realize our own vision for the future. I just want to thank again the Peter Wall Fellowship. I want to thank Kate Shannon for hosting me at the Center for Gender and Sexual Health Equity, all of the funders, all of the teams. I have a book that just came out this year. I bought a copy if you want to look at it, and check out my podcast. And thank you so much.
Thank you so much. That was just excellent. I really appreciate it. I think because we started a little bit late, I will take questions first from the Zoom chat. Marianne, if you're there, if there's anything you want to bring up, and then we'll come back into the room. Is that fair? We don't have a ton of time, and I know Marianne, you had to leave. You had to leave around 1 o'clock.
I'm here, Simona, but there are no questions yet in the chat, so maybe people just need a minute to percolate on some of the content. So
I did speed up to finish on time, so fast at the end.
That's great. Marianne, just pipe in if there's comments that come in. Are there any questions in the room?
Oh, can I ask a question, Simona?
Yeah. Yes, please.
So thank you for an excellent talk. That was great. And I think you kind of alluded to this throughout, but what do you see as kind of the next phase of the SDGs, and how would you like to see them kind of outlined differently to better address some of these issues that you've identified?
Well, I would love them to be more grounded in the realities of the communities that are most affected. So when it comes to talking about the HIV and AIDS epidemic, to look and see who are the people most impacted, and explicitly discussing what are the social and structural determinants of health that are contributing to this persistent disproportionate impact. So if we know that for 40 years that gay and bisexual men, that sex workers, that people who've used drugs for 40 years have been at elevated risk, maybe we need to think about what we need to do differently, and really bringing those inequities that are perpetuating these risks into the conversation. Because I think the more generic the goals are, yes, they capture a lot, but they might not really give enough directives. But I know that that's political, and there's people who wouldn't sign on to them if we mentioned sexual rights or LGBTQ rights. So, I mean, I would like them to mention sexual rights, and I would like them to not have an other category for LGBTQ people and sex workers. So that would be great. I don't know if that answered your question.
Yeah, absolutely. That was helpful. Thank you.
I had a question. And you talked about the refugees, and I'm wondering if the medical humanitarian organizations or the humanitarian organizations, how they're handling this, and are they doing a very good job?
I think that they're I started working with displaced people after the earthquake in Haiti, and I work in the second largest refugee settlement in the world in Bidi in northern Uganda. People don't have enough resources. So I really think that they're doing the best that they can. And the MISP, which is, I'm not going to say what the MISP is short for because I can't think of it right now. The MISP is guiding sexual and reproductive health in humanitarian context. They just kind of refreshed that recently. And it does mention LGBTQ people in there. The challenge is that there's not enough resources. So when we're working in the refugee settlement, and working with health clinics, there's only one place to sit, so you're sitting with everybody that's around, and there's one window for getting your HIV meds, so they started doing testing in the evening, testing after dark, so people could come and get some more privacy. Then they lost the funding for that, right? So right now, I don't know if you know this, but the World Food Program has had to cut rations among refugee and displaced people across the world, which is absolutely devastating. People had rations to eat once a day, and they don't even have that. It's been cut by 60%. So the resources just aren't there. And so they're doing their best with what they, the focus is supposed to be of humanitarian work, which is emergency needs, right? So they're doing that, but they don't have the sufficient funding. We're doing an HIV self-testing study in the refugee camp, and we did one with urban refugees. And we just don't have, they're interested and they want to do the best that they can. They just don't necessarily have the training, the resources, and the support. But we just finished a Grand Challenges Canada post-rape care study in Bidi in the refugee settlement in Uganda. And we had all the healthcare workers came. And when they learned about youth-friendly sexual health spaces, when they learned about stigma reduction, they went and implemented that. So it's sort of like people are open to doing it, but there's just so many refugees and not enough funding that I think this sort of long-term sexual and reproductive health care, it kind of falls out of their vision because they're focused so much on meeting the immediate needs. So people are open. They're open to talking. I work with a refugee sex worker organization and a refugee LGBTQ organization. So people are very open to it, but we need more funding.
Simona, I have a question here. Yeah. So I have a comment first, just some praise of the talk and especially about the flourishing idea. So I just want to start with that. And then a question. So it says, as a Bachelor of Science in Nursing student, I'm often overwhelmed by how little I know about sexual rights and where to start. Do you have any suggestions for how best to address the stigma experienced by individuals engaging in sex work or who identify as 2SLGBTQ+ in my practice?
That's a great question. I think there's a lot of places to start just by, maybe even just going to the website for, I always get the acronym wrong, CGSHE, the Center for Gender and Sexual Equity. You can just look at some of their policy reports, which are around the harms of sex workers. So what I would do is sort of start reading the articles, if you're in Canada, in the Canadian context, about mental and sexual health disparities among LGBTQ people. There's been a lot of people publishing on that, and reading some of the sex worker articles. So there's also podcasts. You can check out my podcast. We have people talking. Dr. Travis Salway was a guest talking about LGBTQ mental health. So I think just starting to educate yourself, about what is the landscape like? Why is there higher rates of suicide and depression and anxiety with LGBTQ people in Canada? Why is there high rates of HIV among gay men in Canada? What are some of the root causes? And people have been writing about that a lot. And what is the reality of sex workers? So looking at Kate's work, Kathleen Deering's work, Andrea Cruzy's work, people here, Shira Goldenberg's work, there's a lot of people who are writing about what is the experience of sex work stigma like. So I'd say, educate yourself as to what are the lived experiences by reading research, by listening to podcasts, by reading blogs, and then B, the personal work. So reflecting on what was I taught about sex work? What are some of my own biases and preconceptions and ideas that might need to be shaken up a little bit? How might I think about this in a different way if I was to sit with somebody and talk to them and really hear their experiences? So in order for us to really, change the way that we've been raised, it helps to learn and listen to people with lived experiences, and then do the reflection on, how would I feel if my nurse or my doctor was gay or trans, and what was I taught about that, and how many people do I know in my life? If unless you're identifying in those communities, then even if you are identifying with those communities, you can look at the diversity within communities. So what does this mean, for people who are racialized and people who are Indigenous and people who might have lower socioeconomic status? So there's so much intersectionality within experiences. It's hard to say that this is the one experience, but I think just starting to read the research that's out there, and there's so many people globally, but even locally. I don't know if you're calling in from Vancouver, but there's people here doing such great work. To start getting to know the issues, and then start reflecting on your own values and beliefs around sex work, around it's funny. I was asked a question about Superman's bisexual son that I wasn't prepared for, which was, what do you say? Me and the person from my government, it's so great, representation, it all matters. What do you say for the people who are against it? And then once you realize there's so many people against it, even the last one of the Supermans, you realize there's a whole group of people who are not ready for social change. And once you see that group exists, I think you might see that you have a bigger role to play in changing the larger world around you. So how do you have conversations with people who hold stigma and discrimination in ways that engage people? I was trained in nonviolent dialogue communication, and I recommend everybody learn that. How do you actually have conversations with people about challenging topics around stigma towards sex work? So once you learn A, about people's experiences, B, about your own self, and then C, learn how to communicate with others. And so you can start being that change, and you can start being that spark that might help people see differently if they are, holding stigma and discrimination in their ideas and their practices.
Well, I'm cognizant that we're a little over time, and I know people have to go to classes. Marian, is there anything on your end?
No other questions here at the moment.
I just want to say thank you so much. That was great. And thank you for putting up with us in our first hybrid event, trying to adapt to the new situation of not just being virtual, but wanting to have some in-person option too. So it was really a pleasure to have you. And thank you so much for coming.
Thanks for having me. Thanks for coming. Spending your lunch time with me. Thanks.
That's great. Thank you so much.